Azotemia is a medical condition that arises when there is an abnormal increase in the concentration of nitrogenous waste compounds, such as urea and creatinine, in the blood. These substances are typically removed by the kidneys as part of the body's natural waste management system. However, when the kidneys are unable to function effectively, these waste products can accumulate in the bloodstream, leading to azotemia. This condition can be caused by a wide range of factors, including kidney disease, dehydration, and urinary tract obstruction, among others. If left untreated, azotemia may progress to a more severe condition known as uremia, which can be life-threatening. Let's look on this case study. A 55-year-old man presents to your clinic with complaints of unexplained fatigue, reduced appetite, nausea, and frequent headaches. He also reports noticing a change in his urine color, which has become noticeably darker. His medical history reveals uncontrolled hypertension. You decide to perform a comprehensive metabolic panel and urinalysis. The results show elevated levels of nitrogenous waste compounds, such as urea and creatinine, in his blood. What is the most likely diagnosis, and what could be the potential progression of this condition if left untreated? The answer: azotemia, progression to uremia. What are the commonly observed signs of compromised renal function? Compromised renal function, or kidney dysfunction, can present with a variety of signs and symptoms. The most common clinical indicators are elevated levels of blood urea nitrogen and creatinine. BUN levels exceeding 10.7 mol/L and creatinine levels surpassing 133 moles/L are typically regarded as elevated and indicative of kidney dysfunction. Other signs may include electrolyte imbalances such as hyponatremia, hypokalemia, hyperkalemia, hypocalcemia, hypochloremia, and hypophosphatemia. In some cases, patients may also exhibit symptoms of the syndrome of inappropriate anadiuresis, which is often associated with kidney dysfunction. The following flow chart shown in page 2 of the book is an overview of the process of diagnosing azotemia, which is a condition where there is too much nitrogen in the blood. The flow chart starts with a box asking if the patient has renal symptoms. If the answer is yes, then the patient is evaluated for acute renal failure. If the answer is no, then the patient is evaluated for chronic renal failure. The flow chart then goes on to provide more specific instructions for evaluating each of these causes of azotemia. For example, if the patient is suspected of having prerenal azotemia, the flow chart recommends measuring the patient's blood volume and electrolytes. If the patient is suspected of having ARF, the flow chart recommends measuring the patient's urine output and creatinine level. If the patient is evaluated for ARF, the next step is to ask if they have oliguria, which is a condition where the patient is producing less than 400 milliliters of urine per day. If the answer is yes, then the patient is evaluated for prerenal azotemia. If the answer is no, then the patient is evaluated for other causes of ARF. If the patient is evaluated for prerenal azotemia, the next step is to ask if they have volume contraction, which is a condition where there is not enough fluid in the body. If the answer is yes, then the patient is treated with fluids to correct the volume contraction. If the answer is no, then the patient is evaluated for other causes of prerenal azotemia. If the patient is evaluated for ARF, the next step is to ask if they have a history of recent kidney injury. If the answer is yes, then the patient is evaluated for acute tubular necrosis, which is a type of kidney injury. If the answer is no, then the patient is monitored for their kidney function and provided with supportive care. What methods can be utilized to approximate renal function? This is done using the formula: creatinine clearance is equal milliliter per minute equal UCR/UV divided by serum creatinine 1440 in this equation. UCR represents the concentration of creatinine in the urine measured in milligram per deciliter. SCR represents the concentration of creatinine in the serum measured in milligram per deciliter. UV represents the 24-hour urine volume measured in ml, and 1440 represents the total number of minutes in a 24-hour period. Another commonly used method is the estimation of the glomerular filtration rate using equations such as the modification of diet and renal disease (MDRD) equation or the chronic kidney disease epidemiology collaboration equation. These equations take into account variables like serum creatinine, age, sex, and race to provide an estimate of renal function. What is the typical range for creatinine clearance in the general population? The typical range for creatinine clearance is greater than 100 milliliters per minute. The assessment of the collection sufficiency is determined by the measurement of urinary volume and the concentration of creatinine. Creatinine is synthesized endogenously in skeletal muscle and is eliminated from the body at a relatively consistent rate. According to established guidelines, the recommended range for creatinine excretion in males aged 20 to 50 is 18.5 to 25.0 milligram per kilogram body weight. Similarly, for females within the same age group, the recommended range is 16.5 to 22.4 milligram per kilogram body weight. According to research, it is recommended that an individual weighing 80 kilograms should eliminate approximately 1,500 to 2,000 milligrams of creatinine during a collection period considered to be adequate. The Cockcroft-Gault formula enables the estimation of creatinine clearance in males, taking into consideration age-related declines in glomerular filtration rate, body weight, and gender. The formula for calculating creatinine clearance is expressed as creatinine clearance equal 140 minus age multiplied by lean body weight, which is kilogram per plasma creatinine multiplied by 72. The aforementioned value should be multiplied by a factor of 0.85 in the case of women. The acronym GFR refers to estimated glomerular filtration rate, which is a quantitative measure derived from serum creatinine concentrations. The purpose of this method is to assess the renal function in terms of its ability to remove waste substances from the bloodstream. What are the limitations of using creatinine as a measure of glomerular filtration rate? While the creatinine clearance formula is a widely used method for estimating renal function, it does have several limitations. Creatinine is a breakdown product of dietary meat and creatine phosphate found in skeletal muscle. Therefore, its production in the body is dependent on muscle mass. This means that individuals with more muscle mass will naturally have higher creatinine levels, potentially leading to overestimation of renal dysfunction. Conversely, individuals with less muscle mass may have lower creatinine levels, potentially leading to underestimation of renal. Creatinine is freely filtered by the glomerulus, but it is also secreted by the peritubular capillaries. This causes the creatinine clearance to overestimate the GFR by approximately 10% to 20%. The accuracy of the creatinine clearance calculation depends on accurately timed and complete urine collection. Incomplete urine collections can result in underestimation of creatinine excretion and therefore GFR underestimation. One of the major limitations of creatinine clearance testing is that it becomes less accurate as the GFR declines because of increasing tubular secretion of creatinine. This results in the GFR being overestimated. The Cockcroft-Gault formula, which is used to estimate CRCL, has its own limitations. It was developed using data from men and is not adjusted for body surface area. It's no longer recommended for use because it has not been expressed using standardized creatinine values. Both the MDRT study and CKD-PI equations, which are based on serum creatinine, suffer from physiological limitations of creatinine as a filtration marker. All estimates of GFR based on serum creatinine will be less accurate for patients at the extremes of muscle mass, including frail elderly, critically ill, or cancer patients, those with unusual diets, and those with conditions associated with reduced secretion. As renal dysfunction progresses, the proportionate contribution of tubular secretion to creatinine clearance increases. Consequently, in patients with chronic kidney disease, the estimation of GFR through creatinine clearance tends to overstate the actual GFR. Isotopic markers that undergo filtration without subsequent secretion, such as iothylamate, offer more precise estimations of glomerular filtration rate. In what manner is cystatin C employed as a means of assessing glomerular filtration rate? Cystatin C is a low molecular weight protein that is produced by all nucleated cells in the body at a relatively constant rate. It is freely filtered by the glomerulus and is not secreted by the renal tubules, making it a potentially more accurate marker of glomerular filtration rate than creatinine. One of the key advantages of using cystatin C to estimate GFR is that its production is less influenced by muscle mass compared to creatinine. This makes it a particularly useful marker in individuals with extremes of muscle mass, such as the elderly, malnourished, or those with muscle-wasting diseases, where creatinine-based estimates of GFR may be less accurate. Moreover, cystatin C is not affected by diet and its levels are not significantly altered by inflammation. making it a more stable indicator of kidney function. However, it's important to note that while cystatin C is a promising alternative to creatinine for estimating GFR, it is not without its limitations. For instance, cystatin C levels can be influenced by factors such as thyroid function, corticosteroid use, and smoking, which can potentially affect the accuracy of GFR estimates. How does the estimated glomerular filtration rate contribute to the categorization of chronic kidney disease? The estimated glomerular filtration rate is a key factor in the classification of chronic kidney disease. The National Kidney Foundation uses eGFR values as a primary criterion for categorizing the severity of kidney disease. The classification system includes 6 categories based on eGFR values. G1. GFR 90 milliliters min per 1.73 square meters and above. G2. GFR 60 to 89 milliliters min per 1.73 square meters. G3A. GFR 45 to 59 milliliters min per 1.73 square meters. G3B. GFR 30 to 44 milliliters min per 1.73 square meters. G4. GFR 15 to 29 milliliters min per 1.73 square meters. G5. GFR less than 15 milliliters min per 1.73 square meters or treatment by dialysis. This classification system helps to identify the severity of kidney disease in patients, plan appropriate treatment strategies, and monitor disease progression over time. However, it's important to note that like serum creatinine, cystatin C levels can also be influenced by factors such as age, race, and sex. Therefore, these factors should be taken into account when using eGFR to assess kidney function.